So finally, I want to just sort of spend a little bit of time talking about some controversies that have come up around using these medications and some of the evidence base right now that is challenging some of the sort of basic framework around symptom management for our patient population. So in late 2016, early 2017, Mira Agar and her team in Australia and New Zealand published a paper in JAMA Internal Medicine looking at using two drugs, risperidone, so it's a second generation agent, and haloperidol versus placebo for the symptoms of delirium for patients who they sort of coined as having kind of palliative care needs. And this was primarily a patient population that had cancer who were in the last months of their lives. And this was probably the first really well done randomized placebo trial that looked at using these medications. And unfortunately, actually what it showed here is that for patients who received placebo, that their delirium scores were actually lower than those patients who had who got risperidone and haloperidol. And so what this actually showed was that patients that received these antidopaminergic medications actually had more delirium symptoms than the patients who actually got placebo. And when this was presented at our national meeting, there was sort of a hush in the room, and everybody was just sort of looking at each other saying, like, I hope, let's just pretend that nobody said that, because this really kind of would change our practice. When we looked at the trial, one of the things that's important about this is that the trial didn't compare drugs against each other. Really, this was sort of comparing risperidone versus placebo and Haldol versus placebo. It didn't compare those two medications against each other. One of the challenges I've had with this trial is that there was a little bit of a bias of using two drugs that were pharmacologically really similar. So haloperidol and risperidone are pharmacologically very potent dopamine blockers, but aren't very histaminergic, meaning they're not very sedating. And so really when they picked these two drugs, they picked a first generation agent and a second generation agent, but they were actually pretty pharmacologically similar. And so we don't know, like, if they had actually picked Haldol and say, or promazine or thorazine, that this may have been a slightly different outcome. And so again, there was a little bit of bias, we think, in the drug selection in this to kind of make this a little bit challenging to put into clinical practice. And again, this gets back to the fact that the medications that they picked were very similar in their sort of sedating profile. So the outcome here was that Haldol and risperidone at low dosage in advanced cancer patients may actually worsen some of the delirium symptoms. And so this sort of kind of flew in the face a bit of how we've been managing our patients. There were some issues with the trial. There was a very low threshold in the trial to treat folks. So patients that had delirium symptoms, they sort of started giving medications probably a lot sooner than we actually would in clinical practice. And we worry that some of the patients may have actually been experiencing some akathisia or other extrapyramidal symptoms. Some of the patients that were in the active treatment arm actually got more opiates. They were more likely to get a benzodiazepine as a rescue medicine. And so right now there's a little bit of sort of controversy about what this means, but I think there's a lot of clinical judgment that should come into this because this was a well-done trial to decide whether or not we should be using these medications in all patients, particularly with cancer, that have delirium. I would say for patients who are really symptomatic, I would encourage their use, but it's been a little bit of a challenge in this past year to kind of figure out what we should be doing. However, a second trial came out that was published in JAMA, particularly in patients at the very end of life. So very much more like what Mr. Jones was experiencing when he got readmitted the second time, where he was pretty much had a terminal type of delirium. And so this trial actually looked at adding lorazepam or Ativan, a benzodiazepine, with haloperidol versus haloperidol alone in patients that had very agitated delirium with advanced cancer at the end of their life. And I'll highlight here that the patients in this trial got a very high dose of lorazepam, or 3 milligrams, which I would argue is essentially a sedative dose, as well as sort of a moderate dose of haloperidol. And what they looked at was essentially their outcome was sedation. They were looking at within about 8 hours of administration of these drugs, did the symptoms of delirium, particularly that agitated delirium, get better after administration of the drug. And just to make sure we're on the sort of same page, so the RASS was their endpoint, which is the Richmond Agitation Sedation Score. And so negative numbers are people who are more sedated. And so the anesthesiologists use this a lot when they're doing surgery to sort of figure out where people are, for example, if they're on the ventilator, to tell us how sedated they are. So a RASS of -3 really is where a patient may open their eyes briefly to voice, but really can't make eye contact and they're pretty sedated. And not surprisingly, when they gave a sedating dose of a benzodiazepine, and what this shows here is that patients who got placebo weren't very sedated. They were pretty much almost alert and calm, whereas people that got the Haldol and lorazepam were quite sleepy. And so what they showed was that if they gave this combination, that patients who were agitated and having delirious had an effective sedation outcome. And so the question was, you know, this shows that we can treat patients who have agitated delirium close to the end of life who have cancer with this combination. And what they actually did demonstrate was that there was no adverse effects and people didn't die any faster, which actually I think was probably the most important outcome, because there was concern that if we use these medications, particularly things like Ativan, that people's delirium might get worse. It's sort of disinhibiting, it's kind of like alcohol, or that it might enhance the time to dying, that it might speed up people dying. And they didn't actually show that in this trial. The problem with this trial, though, is that it's kind of limited to our patients at the very end of life with cancer. And so doing this sort of an intervention like Haldol plus this high dose of lorazepam would be very inappropriate or even harmful in other scenarios or situations, particularly if this was like a reversible delirium. For someone who you're just treating pneumonia, would never want to give this degree of medications. And so what I think this does show, and sort of similar to what happened with Mr. Jones, is that higher doses of a benzodiazepine, particularly lorazepam, can be used to decrease delirium symptoms simply due to the sedation, which may be desired if the conversation has been that the goal of care would be, say, comfort over consciousness, where the patient would prefer to be sleepy at the end of their life if they're really agitated and delirious and psychotic rather than be awake. So I think there's a very narrow focus of how this can be applied. So I hope, as we've talked about, this has sort of given you sort of some context for the different types of delirium, how we sort of think about dopamine pharmacology, some selection of medications,